Hi, everybody. And this is Dr. Andrea here with Expect More. And on today's session, we have orthopedic surgeon and bare implant extraordinaire, Dr. Lisa Kaplin. Dr. Kaplin, welcome and thank you for your time today. Why don't you tell us, all our friends, a little bit about your background and what you got going on and what we can look forward to talking about today.
Sure. So thanks for having me. This is great. Love opportunities like this. So my name is Lisa Kaplin. I am an orthopedic surgeon. I have a subspecialty training in sports medicine, and I am currently living in Pennsylvania. I grew up actually in New York State, and I went to college in Boston area at Brandeis University. It's a small school, not too far from BU in the downtown area. I did a master's program then actually at BU in medical sciences before I went to medical school. And then I went to medical school at the University of New England, which is up in Maine, which was cold. It was great. It was very cold. And then I did I did a residency at Philadelphia College of Osteopathic Medicine, which is in Philly. So that was 5 years, and then discovered I wanted to do a sports medicine fellowship, which is when you do an extra year after your training,
Hey,
just
why
keep
not?
racking in the years.
Yeah.
I think I've calculated at this point, it's like 15 or 16 years of like education, and then I just want to
Wow.
slap myself. What the hell did you do with your life? You're still in school.
So
Yeah,
smart.
so
Smarty.
that Wake Forest I went to for my sports medicine fellowship, and then I finally became a real doctor. I was a doctor after med school, but then you finally become attending, right? And then you start working and you start taking care of your own patients, and then that's when the rewarding stuff happens. So currently, I'm in Pennsylvania. I was in South Jersey for a little bit, back in Pennsylvania,
Boo-boo
but
lip.
it's good to be here.
No comment. I said I would behave.
It's
No,
all good.
I'm super happy to talk to you. We were talking off camera a little bit before just about some things. And for me, it's just so refreshing to be able to talk to real surgeons, real people that have real personalities behind all the accolades and whatnot. So I think it's great for a couple ways. One, that you trust me to come on and have this discussion. And two, that people get to see you and what resonates with them about the care you provide and some of the things that you've seen over your career. It's important. I think it's really important for people to understand that there are still healthcare is shifting like crazy, but there are still really great people, really intelligent people fighting the good fight to provide really good care in a compassionate manner, and you're definitely one of those people. So
Thank you.
thanks.
I appreciate that.
Yes, it needs to be said.
And
It's not
you
said
are one of
enough.
those therapists. You are one
Uh,
of those people.
Thank
It's
you.
so great to have been connected with you.
Yeah, no,
So
same. It's really nice when it resonates and we, try and put the patient on the
yeah,
pedestal and make sure we take really good care. And the trust between the surgeon and the PT, it goes both ways. Like good communication is always like
yep.
top notch for me, and you're stellar at that. So thank you.
So you know what this means? You need to open a satellite office in Pennsylvania.
I promise I would behave on camera. Now you're baiting me.
All right, there's
All
it.
right, we'll
There's it.
see.
There's
We'll
it.
see. We'll see. We'll see. Maybe. I don't know.
Next up.
Yeah.
Because you don't have enough to do.
Yeah, no, I love doing this. This is good stuff. All right, so talk to me a little bit about what inspired you to start your journey, especially when you talk about 15, 16 years of schooling. I mean, it
Mm.
sounds to me
Hmm.
when we look at that, there was something that just kept triggering you for the next phase, right? You were like, oh, okay, I got this. Oh, wait, I think I can add to this. So what kind of inspired you on
Yes.
that journey?
Yeah, that's a good way of looking at it. I think, we've talked about sports and being athletes,
Yeah.
and I think it's always like that awkward cliche sort of answer. You're like, "Oh, I was an active person when I was younger. I played sports. Oh, I'm an orthopedic surgeon." Like it is some element of truth. I think there has to be some sort of truth behind, okay, why do people decide to do what they're going to do? And I think the things I enjoy doing physically, playing soccer. I was a swimmer. I swam a lot in high school. I didn't swim in college, but I played soccer. And I think just always being very in tune with health, right, and fitness and being active. And it almost got to the point and I liked science, right? So then you're like, okay, there was this element of like, I liked science. Like I knew I wasn't going to be a professional soccer player at some point. It crushed my dreams. I was like, I'm not going to be a professional soccer player, but what can I do where I can sort of stay in touch with a physical aspect of like life, right, and connection with other people and myself. And so for me, it was like playing soccer in college. And honestly, almost it sounds funny, but being able to see what people and especially athletes could do with their bodies before they get injured, almost like superhuman stuff. I mean, and just that element of like injury and then rebuilding after injury, and success stories like that really resonated with me. And I didn't really know what orthopedics was. And so I was sort of doing pre-med because I liked science, like the health aspect of things. And then I started shadowing a couple. You're like, okay, well, you're going to go to med school. What are you going to do? And then there was, of course, like primary care, sports medicine, which was cool. I was like, okay, this could be good. I can, be working with athletes and doing things like that. And then there's a whole other side of surgical subspecialties, outside of the medical
Yeah.
subspecialties. And so I shadowed a couple orthopedic surgeons, and I was like, this is cool. This is where it's at.
That is
Like,
cool.
realizing not everybody you meet, most people you meet as an orthopedic surgeon, you're not going to do surgery on, right? That's important to remember. But you get to develop those relationships with people, and you get to, and I think people have a different level of connection when you're a surgeon with them, right? I mean, I think
Oh
there's a
yeah.
different level of intimacy there and sort of responsibility, that goes along with patient care. And I really liked the stuff I was seeing in the OR, and those relationships I saw those surgeons working with patients. And so then the residency part of it was easy. Okay, orthopedic surgery residency. And then the fellowship. So then it's like, okay, that 15th, 16th year of training, why is that so important? And truly, like the year of my fellowship at Wake Forest was by far like, it's like the golden year. It was like the year where I learned what I make in practice now. So
Okay.
the things that I do in practice now, most of that is what I took from fellowship. I mean, you need to learn the bread and butter stuff in residency,
Sure.
but then that extra element of training, where you're really getting into some cool stuff, is that fellowship year. So I'm like, okay, sports medicine, here we come. Like joint replacements were cool, they were right. Didn't want anything to do with the revisions though. I was like, nope, not for me. Sports medicine, it's nice, it's good lifestyle. There's not a lot of sports emergencies, right? Like sports medicine emergencies. Covering
Hmm.
games, certainly there's stuff that comes up then, but it seemed like a good fit.
No,
And I think it was.
it sounds like it was, and a little bit to your point, like I had when I was on my clinical rotations, because PT school was a 5 year track for at the time it was a dual bachelor masters. I observed surgery, so I observed the first surgery was with actually a female surgeon, which I was like, in 1998, you were like,
Uh-huh.
wait, what?
Minority.
Like,
Yep.
no, definitely wasn't a thing. And this was in the middle of nowhere, Pennsylvania, that respectfully was like kind of exciting to me. So I remember I observed surgery and they're in there like hammering away on this hip replacement. And she had me right in next to her. She was so cool and really gracious about teaching. And I went home that night and I was obsessed. I'm like, oh my God, I think I need to go to medical school. I want to be a surgeon. So I start like, I don't even know what it was, AOL probably at the time. And I'm like
Yeah.
trying to look things up. But I'll tell you what, Doc, I saw that track of schooling and I was like, I'm only
Uh-huh.
6 months away from graduation. I'm good.
Yeah.
So,
You made the right call.
nah, I don't know about that,
No, I
but
mean, I love what I do. It is a lot of years. It is a lot of dedication.
it's so
There's a
cool
lot of
though.
loans.
It's a lot of loans. I
A
had
lot of
already
loans.
racked up enough of those. So
Yeah.
and honestly, there's something about being the end all be all. Like that was a big thing too. Like in my mind anyway, like you literally have, and this is something that I know isn't lost on surgeons, but sometimes it's lost, I think, on the general public. When you go in for surgery, your surgeon is accepting full responsibility for you as a person, you as a, as an injury, and restoring you back to not just a prior level, but an accelerated level of where you live. So that's not a small thing. And it takes a lot of
Yep.
time, effort, and schooling to refine those. So beast mode, really. I don't know how you sleep. I don't know how you guys do it.
Not well. Not
Yeah.
well.
I don't
A
know
lot
how.
of nights, not well. But you know what? Young kids help with that because they exhaust you. So then you're
True.
just overly
So you
exhausted.
just go night night when you get home.
But
So
but yeah, no, you're right. It is a big the operating room, it's a place. It's a place where you kind of go, and it's almost like a performance, right? In some ways.
Yeah, so like leading into that, like what are some of the non-negotiables for you? Like as a surgeon, like things not just like, the nice to haves, like, I'm sure you have a music track and whatnot to keep you focused, but non-negotiables as far as qualifiers for surgery, like things that you're looking for that are maybe less emergent than a complete ACL rupture. Is there anything that like kind of sticks out in your head as far as I'm seeing a shoulder and they're in that middle zone, like what are some
Yeah.
qualifiers for that?
Yeah, so that's so these are discussions that again, I think people who are insightful about their making their own decisions and being sort of autonomous in that way, like come into the game and they expect those sort of conversations. I mean, some people come in and they're like, just tell me what to do. And it's
Yeah,
like, no, right? I mean, certainly things that can help
sometimes.
guide you, right?
Sure.
Right. There are those non-negotiable things, but a lot of times it's really more of a conversation, right? And you want to do what's right by that person, and what might be right for you might not be right for someone else, right? With the same exact pathology. I think the non-negotiables you mentioned, like, with regards to knee injury, so an ACL tear is an interesting topic because they're very common, and a lot of them need surgery and some of them don't. And I think when I have people who come in and with their MRI, a good example, someone who comes in, like they're handing me their MRI and they're maybe in like their mid 50s, even 60s, right, and they've already got arthritis and their ACL is torn, possibly even because they have arthritis, and they're just focused on the word tear, right? My meniscus
Right.
is torn, my ACL is torn. I have to actually do a job of convincing them that they do not need an ACL reconstruction, right?
Mhm.
So not just a certain age, but a certain level of pathology of what's happening in your knee, you're actually not really a candidate to have an ACL reconstruction. And some people who are sedentary or in their mid 40s and early 50s, like they may not need you don't need your ACL to have a functional knee. You
Mhm.
need your ACL to do certain things with your knee. And that's where it's like the 20-year-old who maybe tore their ACL playing a sport and wants to get back to playing sports, but they feel pretty good 2 weeks after they tore it because the swelling's gone down. They're like, I'm walking normally. I'm like, you need surgery, my friend.
Yeah.
I think that those are the clear cut ones. I look at age and activity level. I
Okay.
think those are the two things. So if you are a young person, I mean, young, I guess is relative. So if you are like, okay,
Careful,
well, am I
careful.
still young? Yeah. So activity level, right? We can just
Right.
leave it at that. Even to be
No,
honest, to,
no.
to be honest, I mean, I've done an ACL in someone people in their 50s, right?
Mhm.
And I think you ask a 20-year-old, is someone in their 50s old, they'd say yes. But
Yeah, oh
you know
yeah,
what?
for sure.
Someone who's active, and they have pretty good looking cartilage and the rest of their knee looks good, and they want to get back to skiing, they play in a women's basketball team, or something where they're
Yeah.
using, they should have surgery. And the risk comes where if you don't and you try to get back to those things, even just running, but really it's the side to side, the lateral moves, the cutting, the pivoting. You try to go back to a sport without an ACL, you know, there is a risk. I don't want to say you definitely will, because some people do it and they do it successfully, but you
Mhm.
run the risk of re-injuring other things in your knee, like your meniscus, like the cartilage, which is an important thing. Um, but but some
My
people can do
husband,
it.
yeah, my husband's perfect example. So he was an ice hockey guy forever, like from 12 all the way up. So ice hockey, traditionally you have those very muscular thighs that create that stability, so to speak.
Yep.
He somewhere along the way tore his ACL, wasn't aware that he tore his ACL, continued to play ice hockey on this. And that shearing, my poor
Hmm.
friend, my partner here has a terribly arthritic knee at a relatively young age because
Yeah.
of all the shifting. He eventually had it done in his late 30s. He had it done, but it was already pretty damaged as far as the surfaces.
Yeah.
So,
Yeah. It's hard. And then there are people who, they can live mildly active or sedentary lives, and they can rehab it, right? I mean,
mhm.
non-operative ACL rehab, like that's,
That's
that
definitely
that's some of
well,
that's some of what you do. I
it's
imagine. I mean,
it's
no,
one of
you
my
rehab the post-ops, but they
no,
can do
it's one of my
great.
favorites actually because they do really well, and
They feel a different level of confidence probably once they go through it. And
yeah, I mean, one of my favorite cases was a lady that was an avid horseback rider, and she ended up just with a little bit of an offloading brace to help,
yep.
minimize some of that strain. And she did amazingly well. Went back to riding horse. That's all she wanted to do, really, is live her life and ride horses. And
Yep.
no
Yeah,
surgery,
that's
and she would not have enjoyed surgery
right.
or the recovery period at all. Yeah.
And that's for me as a surgeon, it's like I always think like you can always do more harm with surgery, right? It's like, infection, post-operative knee stiffness. Like there's always things that you can bring on, neurovascular damage, right? Like those things don't happen the majority of the time. But I
Right,
always
right,
tell people,
right.
you have the choice. Like this is a conversation, between me and you. Like we're embarking on this together. I can give you my opinion, but there was like a Peloton instructor I had at one point, and it's like their motto was like, I make the recommendations, but you make the decisions. And that
Yeah, yeah, yeah.
I love that about orthopedics, like
Yeah.
because the patient really is in the driver's seat a lot of the times. I can just sort of say, these are the risks if you do X, and these are the risks if you do Y,
Totally. Yep.
right? And really kind of, it's not like, your appendix burst and they're like, okay, you need surgery. Like,
Right.
that's
Right.
different. But like with orthopedics, it's really nice in that way.
No, and I think that's another reason why we get along so well with that, because that's really, when we talk about return to play decision making, that's a big part of it, which is like, hey, listen, you can still play. There's nothing here
Yeah.
that's indicating to me that I need to tell you not to play. However, if you keep playing, you're probably still going to run into these issues, and you're probably not going to be able to play as well as you could if you did a full shutdown and took care of it for a couple of weeks. So totally get it.
Yep.
Talk to me about like cartilage lesions and what that is, and like, since we were talking about the articular surfaces wearing away, like what do we need to know about that? Because there's some new
Yeah.
cool stuff that's been going on, I think, the last
Yeah.
couple of years.
So, cartilage is that term, I try to use it. I probably, when I talk to patients about, cartilage, I probably use it too soon and explaining, okay, what is cartilage, right? Because there's actually different kinds of cartilage in our bodies, but, specifically we're talking about the knee. So there's something called hyaline cartilage, right? And that's actually the nice, smooth substance that lines all our joints. We have it everywhere. We've got it in our small little finger joints, our toes. It's in our knees, our shoulders. And that tends to be like a more of a lubricant and a supportive type of cartilage. Then you have fibrocartilage, which is actually what our meniscus is made out of, right? So when you say cartilage, kind of have to, people use these terms and they sometimes don't know what they're saying, and people focus on their meniscus injuries. Everyone's worried they've got a torn meniscus. A lot of people do have torn meniscus, and sometimes it matters and sometimes it doesn't. The reality is, if you have a torn meniscus and you also have no cartilage left in your knee and your bone is exposed, meaning no hyaline cartilage, it doesn't matter you have a torn meniscus. And that's so I educate a lot of people just on like, what is cartilage, like what are we talking about, because what arthritis is, which eventually plagues us all, I think. I feel like if we're all to, I say that if we're all to live to 100 years old, um, most of us would have arthritis, right? Probably like 90+% of people. So cartilage, like hyaline cartilage, is very important because that's the protective substance of our joints, of our knee, of our shoulders. And as a sports surgeon, I'm trying to preserve your native anatomy before these joint surgeons come in and they just want to replace your joint, right? Because that's like
That
their
is
goal. They're
true.
like, I mean, that's kind of like the end path. So I try to do the work on the front end for people, whether they're an athlete or whether they're not an athlete, but just an active person or in pain, and try to really save their joint. And so when you can look at the cartilage and say, okay, if someone has a focal area, I'd say it's sort of like a circle or something of a defect, and they can happen. Sometimes they're congenital. People don't even know they have them. They can happen from trauma, right? An injury. You see a lot of times cartilage injuries with ACL tears, because when you
Hmm.
think of like the knee shifting on itself,
Hmm.
it's hitting the two bones are hitting each other. So the cartilage is hitting each other on the lateral femur and the lateral tibial plateau in order for the knee to pivot and then the ACL to tear. So there's almost always some sort of cartilage injury, right?
And
When you
really,
tear your
you liken
ACL.
that to like instead of being a very smooth surface with bone on bone, like not bone on bone, but like gliding surface, it's more like little craters or a little crater, so
Exactly.
to speak. So there's
Yep.
that incongruency, right, with the
Correct.
the surface.
And
Okay.
I explain it to people, even as I have a couple pictures in my office. Like if you think of like a sidewalk that's just been paved, right? That's
Hmm.
beautiful. And then what happens over time, whether it's like the winter, the wear and tear, you start to get little cracks, right, in
Oh,
the
I love
sidewalk.
that. I've never heard
Yes.
that one. I like it.
And that's, you can picture exactly what that looks like,
Yes.
right? It's
Yeah.
like it's like what you're going to hit and then you're going to fall over it. So it's like a little crack in the sidewalk, and that's kind of like early stage. And then you can actually start to like it fissures a little bit more and you can pull it up. right? And then you
Mhm.
get sort of the underlying, not nice looking sidewalk, right? Or bone in this
Mhm.
case.
Mhm.
And then that's when bone is really exposed, and then you have nothing. And that's sort of like a stage four. We call it like a grade four defect. So there are cool surgeries for people who have these focal defects who are
Okay.
young and they don't have diffuse arthritis. Once you have diffuse cartilage damage, we call that arthritis. I mean, that really is what arthritis is. Um, but if you can prevent the progression of something that's this big, right, to making it so that it's not the whole, femoral condyle or whatever we're talking
Mhm.
about,
Mhm.
there are some cool procedures. There's allografts you can use. There's autograft. You come from your own knee. There's synthetic forms of cartilage. There's a couple procedures for larger defects. Osteochondral allograft is the name of one of them, where you use a
Okay.
plug from a donor, and
Okay.
you literally, it's kind of like arts and crafts, right? You sort of plug it, you have the size, call it the recipient and the donor, and you literally are putting the plug, right in, and it looks smooth, and you're sort of, it's the right shape. And then there's a procedure called Macy procedure, which is, it's been around for a little while, and there's new waves of it that they continue to create. And there's now an arthroscopic form of Macy, actually, which is cool. I don't even know if we talked about that. So
Mm.
they're traditionally been done open. So you're making a big incision. There's actually now an arthroscopic instrumentation that's been developed that is really only in the last few months. So you can do a cartilage restoration procedure where you're filling something this big through pretty small incisions. Again, this is just how technology is advancing in the field. But that procedure is when the person actually, you go in and you scrape some cartilage from their knee on a non-weight bearing part of their joint, and you actually grow it in a lab for about 6 weeks, up to 5 years. And it really is, and it's exponentially growing. So you're using their own cartilage cells, you're growing it out on a scaffold, it's a pretty thin membrane, and then you're reimplanting that sometimes months, even a year later.
So
So it,
crazy.
it, it
So
really is
cool.
science at its finest. And so that's cool stuff that, I always think like, okay, what do my like colleagues and like therapists know about these surgeries and rehabbing them? Because it is a different rehab earlier on. And, we talked about the bear too, which is a different rehab, as earlier on than
Yeah,
your
I mean,
typical.
they don't push. So here's the funny part where, funny, I say funny, haha, but funny, ironic, because as these medical advances are taking place on your side of things, and you're training, surgical teams training, and you understand the science behind it and the procedures, there's no one that's keeping us up to date with these advances on how to handle these, other than experience level. And what always is astounding to me, really, just, and I won't get on my soapbox too much, but um, if you don't know what the Macy procedure is, you should not be rehabbing the Macy procedure. And you should really not, or without some sort of guidance or discussion, because it is not a meniscectomy. It is
Right.
not a meniscal repair. It is very different. And when we received our first, we've done a few Macy's and a few Bears. And the first bear patient that we saw, man, I sat down. I spent almost a full day. My partner and myself, Antoinette, we sat down and just laid out. Okay, this is what we know. 25 years of
Hmm.
ACLs, not even close to the same. So
Yep.
there's definitely a gap when you say, what do our therapists know? It's there's a gap. And one of the things that, I think my motivations for doing just these discussions is that, like, pushing that out there, so that, one, the general public knows that there are more advanced techniques that potentially you could qualify for, that will accelerate and improve your quality of life, because that's really what we're trying to do with surgical interventions. And the other is PTs. Let's go. There's stuff out there that you need to know about. So let's
Yeah.
pick it up.
Yeah,
So
and honestly, like that, your crew, I mean, communication's huge, right? I mean, we talked about that sort of offline, but sort of knowing like, okay, this is what I'm familiar with, this is what I'm not. Um, like I love coming to give talks. I gave you guys a talk, doing talk, because like that's where like it's a you ask questions, right? You don't have to feel embarrassed about asking questions, right? And it's like or feel stupid. I mean, it's the same thing. Like I was an intern or resident, like nobody wants to be that one who's raising their hand, right? But everyone's thinking it, everyone has the same questions. You have to ask, I mean, to learn and to sort of, like you said, keep up with what's happening and what's changing in the field. And um and yeah, and just keep growing. And that's how you get good patient outcomes.
Well, it's a growth mindset all the way around, really. And sometimes that finite mindset, I think, creeps in. And it's not just my profession, it's everywhere, really. Just in general, I've been on this journey for 25 years of my career. I definitely don't practice the way I did 20 years ago. I don't practice the way I did 3 or 4 years ago because it's just evolving. And, that's my challenge really to our profession, the PT profession, is make sure that you're continuing to grow. And if you're stagnant in a place, you're probably not in the best place for your career, especially like all these new guys that are coming out. There's so much more to know now than there was 15 years
Yep.
ago with different levels and not as much opportunity for learning. So the fact that you go out and you respect our profession enough to go out and give us the time, which is always challenging, is much appreciated. So don't
Oh
stop
yeah.
doing that. Thank
You
you.
guys, honestly, I tell patients that I say, look, post-op patient, you see me like 6 weeks, 3 months, 6 months, like a very specific amount of time. Like your relationship with your therapist, like I'm very much like relinquishing control. And again, that's where it's important, I think, to like make sure that I feel comfortable, like I feel comfortable with you guys.
Yeah.
Like make sure you
Yeah.
pick, you almost have to hand pick your therapist, right, for certain things and say, okay, this is the person you want to go to for X, for Y. Because I am very much putting my patient in your hands, and you have a huge, huge role. You're seeing them 2, 3 times a week. They're
Don't
your
mess up your
person,
work.
and it's like, well, not even that, but you're
Yeah.
rebuilding that with them. It's a nice little like symbiotic relationship, um, yeah, and I'm glad you mentioned about if you're doing the same thing you were doing, like it's the same thing with surgery. If you're doing the same thing you were doing 10 years ago, something's not right.
Yeah.
Because with surgery, it is a constantly advancing field. There are constantly new implants, right? Things that we use in patients' bodies that are coming out that are changing outcomes. And if you don't follow the research, you don't follow outcomes, then you're going to kind of fall behind. So I'm
Yeah.
glad
And
you mentioned that. It's the same
yeah.
way with therapy, I guess.
No, well, yeah. I mean, I will talk all day about that, but
Changing what you do,
different.
yeah,
Yeah. Yeah. I mean, there's only so many times you can watch somebody do a straight leg raise after knee surgery. I mean, you just like, come on. Like, there's got to be other things or ways to accelerate we live in a tech world. So why aren't we living in like
right.
a rehab savvy, tech savvy rehab world? So, I mean, but,
Yep.
I'll go off on that kick all the time. So, let's talk about this is a good one. Any pet peeves in PT? This is my favorite question to
Oh,
ask.
I mean, I
Any
think we kind of hit.
annoyances, and not to pick on anybody, including us, like, what
No,
else?
you guys, no. I mean, if even if I was talking to some other company, I see you guys are perfect. You guys have done everything great with my patients. You really have, and I'm not just saying that, like giving you the shout out. No, and honestly, it starts with so reputation's huge, right? So you guys have a great name for yourself. Even before I was in South Jersey, or right when I got there, like, people know who you are. They know what you rehabbed. So yeah, it's true. I was a newbie to the area, so it was like, oh, okay, let me check these people out, right? Get in touch with them because maybe they can help me. We can have a good relationship. And then I think like communication. Like I know we said that a couple times. Like if you if this like my I guess my pet peeve would be sort of lack of communication.
Okay, yeah,
So right,
same.
so especially with a therapist who I don't know as well. And I'm like, okay, this person, and I always ask the patient, okay, who are you rehabbing with? Especially if it's like one of your little babies, right? Like I consider all
Yeah,
my ACLs my babies. Some of my big cuff tears, those are my babies. Like I'm, meniscus root repairs. Like there's certain patients you're just like, okay, let me make sure this person's progressing how I want them to progress, not just a run of the
well, they're
mill
complicated.
meniscectomy.
They
They're
are
complicated.
complicated.
They all might hit different challenges, different points in their rehab,
Mm-hmm.
So I think for someone who's maybe like a newer therapist with me, and even though they might be great at rehab and ACL, like I always say, okay, this is my first of all, they have the office number. I always say, this is my cell number. Please reach out. Let me know if there's any issues. I know, text from you guys. Like I'd rather have that than like radio silence and like not hearing. And then I see the patient, and this happened with one patient. Somewhat recently. She's fine now because then I have to look at them. I put the scare in their eyes. I'm like, if your knee's not moving. So she came in and she was like 6, 8 weeks out from ACL, and she had like her extension wasn't bad, but she had like 60 degrees of flex. She just wasn't moving. And I'm like, and she thought she was doing fine. 60 degrees of flexion by 8. I'm like, we got a lot of work to do. Like that's when I'm talking about an MUA almost. So I was like, you gotta. And so I called her therapist up. I said, look, like if there's two problems here. One,
Sit
if you
on them.
think well, if you think that that's appropriate, then that's a bigger problem.
Right,
You know what
right.
I mean? Like that's not a, and then it's like, okay, well, maybe you're not the best person to be rehabbing ACL, but yeah, I always want to give people the benefit of the doubt. I'm like, let's work
Totally
together.
agree.
Like she's comfortable with you. Let's see where we can go with this. Just
Yeah.
please communicate with me. We got to be in touch with her. I want her to have a good outcome. And then and so I saw her back 2 to 3 weeks after that because I was like, this is what you need to work on. And we're going to do a recheck, sort of a exam, another recheck of your exam. And she was like moons better. She was past 90. I was like, okay, I'm feeling more comfortable.
Solid. Yeah. Yeah.
Yeah. So I think the
Yeah.
communication is really important for me. And I would
Okay.
say especially someone who, might struggle a little bit, patient wise, you got to communicate about that person a little bit more.
Yeah.
The
No,
people who are
I
on autopilot, it's not as big of a deal.
totally agree. It's really just communication back and forth. And I always panic. Like, I mean, we're just ACL. I'm so picky. I'm such a PT snob when it comes to ACLs. Like, we're very
Good. That's
specific.
why we like you.
Yeah, 2 weeks, 0 to 90. Like, day 2, 0. Like, I want you straight before you leave
Yeah.
the office, kind of stuff. It just because later on, like, we just presented up in New York on this to a large rehab facility. Later on, if you don't get the basics right, later on, it causes so many problems, and then you're just constantly
Yep.
dealing with the current issues plus the old issues.
Yeah.
So,
The first 3 months, I think, and I know I mean, if you have
yeah,
to, are like the most important, like that
agree.
motion, right? Getting the swelling down, are really just sort of like, that's going to set the tone for everything
Totally,
else.
it sets the stage.
Yeah.
That's what we were saying. I'm like, I feel
Yeah.
like the highest skill set is in the first phase of ACLs and the last phase,
Yes.
like for return to play and what that looks like and how to determine if they're ready, et cetera, et cetera. It's like,
Yeah.
it's a challenge for sure.
And
And
for
I,
you, probably like communication, like having a protocol is probably helpful for you. But even, I
so
mean, probably
helpful.
not, like, what you're doing enough where you could probably not have a protocol. But for people who aren't as subspecialized as you guys and are as good as what you do, they having a protocol for them is like, okay, instead of just saying, okay, ACL and rehab their knee, like it's a two-way street. Like I want to provide you guys with like,
Yeah.
okay, this is, and then vice versa. So
Yeah, well, and then the protocol, I mean, that was a big part of our talk too, because people panic over protocols. It's like, they'll move from phase 1 to phase 2 when they're not solid with the activities in phase 1, and just because it says phase 2, you
yeah,
don't
no,
have to right,
there should
right.
be a
So
disclaimer at the bottom. Like,
I know. And I'm just like, it's just, I don't know. After all these years, I've seen so many protocols, and some of them haven't evolved at all, which is totally fine. I've been involved in writing some protocols, which I, I, I like and not like at the same time, because there's a sense of responsibility on top of that, that I'm like, I'm not the one cutting. That's all you make those calls. But I like having the parameters, and then being intelligent enough to have the wiggle room on what that looks like. Um, Now you had sent, we were talking about research and whatnot, and so I didn't read all of it apologetically, but I did read enough to have an intelligent discussion around this. But the title of the article is "Effect of Sex on Anterior Cruciate Ligament Injury: Related Biomechanics During the Cutting Maneuver in Pre-Adolescent Athletes." So can you explain that a little bit to, everybody, and let's talk first, let's identify what pre-adolescent means. I would imagine it's before
yeah.
13, younger than 13.
Right. So before 13, and so this particular subset of kids were 9 to 12-year-olds, males, females. And so the general premise, I mean, won't bog you down with all the details, but
Yeah.
injury prevention, right, is huge. And we talk about, I mean, yes, they were in this they were talking about specifically they were doing ACL data, but I mean, you could argue, right, like little leaguers, you could argue with anything like that
Little
pre,
league elbow, all the things.
yeah, Little League elbow. Really any, I mean, a whole nother topic of conversation is
Yeah.
like single sport specialization before the age of 13, right?
Yes,
Because
ma'am.
that's a
Yes,
problem.
ma'am.
That's a problem. That's a different conversation.
Yes, it
But
is.
this article was really looking at, okay, we know females, well, most of us know females tear their ACLs at much higher rates than males, right? Like, crazy, like 7 to 1, 8 to 1,
Yeah, it's dumb.
some articles. So, and that is multifactorial, and there's a lot of other articles on that too. But one of the factors involved is specifically the way that females jump, land, pivot, cut. So when they're playing sports, so really all of the non-contact things. It's not like someone's coming at you. If you hit a 9-year-old from the side, boy or girl, you same similar type damage, but it's that
Sure.
non-contact pivoting, and landing mechanisms. So the article was really looking at, like, you take a subset, like if we target these kids before they sort of are fully mature, their muscles are fully mature, doesn't make a difference. And so the 9 to 12-year-old group, what they found is that's actually a great age group to target on how to jump and land, because they didn't find that there was any difference between males and females after they fatigued their muscles. So
Okay.
they put them through a series of tests, they fatigue their muscles, and then they put them through the same series of tests, and
Okay.
they were the same. You would normally expect the females would probably have a couple more injuries, right?
Hmm.
Like, as that, at least that would be the hypothesis, if females are tearing their ACLs more from jumping and landing. So I think targeting that age group when they're young is really, this kind of highlights the possible use for that, and
Yeah,
really diving
no.
into that. Because if
Uh,
you wait till they're in high school, you've missed it.
well,
You
they
know,
develop these patterning, these neuromuscular
yeah.
patterning at very early ages. The challenge has always been, because I'm a huge, huge, huge proponent of injury prevention, and not in the sense of like trying to build a business around it, in a sense that I've seen 25 years worth of ACL tears, hundreds and hundreds, probably thousands over 25 years. And it is so depressing to watch a teenager
Hmm.
come in, watch their psychological warfare that they do on themselves. They're removed from their team. They can't, do the things they want to do. And some of the research here, the percentage of reduction in injuries is so high, like so high, if you would stick to some sort of planning, or
Yep.
like incorporating the planning prior or after practices. And that's like one of our current, my personal, like, rah rah things, is to make sure that we go get these kids and try and teach them how to be better athletes just by moving better,
Yep.
and being aware of it.
Yeah, and I think, the age aside, but even just like what we've shown with stretching. Like, I remember when I played soccer in college, and you probably remember same thing with softball, you know, you don't even, like, you get around in the circle, you're standing there, you're statically stretching, you're like, you're doing, like, the legs are wide, you're pulling up on your ankle and stretch, and now there's obviously a whole lot of dynamic stretching, and it should really be like a certain type of workout for like a third of your, if you're practicing for 2 hours, like a third of your practice time should be really geared towards like keeping your muscles a certain way to avoid injury,
I
because
mean,
it's,
do you think there's enough, and this is just me, like, dreamer mode here, like enough research, and based on what this publication is saying, the evidence is saying, that instead of putting kids in skills camps between the ages of 8 and 10, we should be putting them into how to be an athlete camp, like how to
yes,
run, jump, and cut camp at that age?
yes, neuromuscular training camp. Yeah,
Yes.
I wonder how many
I'm
people
taking
you think
it.
are going to sign their kids up for that. They're going to be,
None. Zero. Zero. Unless I can
you know
promise
what?
them that their kid's going to be a better athlete, which they
Right.
will. They will automatically translate into being a better athlete.
That's why the ones who join, when we have this camp that we're going to come up with, that we're
Yes.
going to do,
Totally doing it.
none of that, we're going to have to study it, then we're going to have to make a study and show the percentage of kids that had injuries after they did our camp, and the ones whose parents threw them right into their, like, single sport, oh, you're only allowed to do baseball at
I know.
9. It's, how many of them are still pitching when they're 18, 19, and they're not out with injury when they're getting recruited for colleges.
I,
It's going to be
I
a long-term study, but we can do it.
no. Well, we can totally do it, but one of the
We can do
reasons I
it.
know we can totally do it is my daughter. I swore I would not be the parent that was 12 months out of the year single sport, and here we stand, as we come into high school, travel ball high school. But she is coming in for recovery stuff simultaneously. So we'll
Good.
see. We'll see. And she's a pitcher, so we'll see how that rolls through.
Yeah.
But
And it's really just that, like, there's a certain, it's probably like around that 12, 13 or so age, right? I think it's like those like
yes.
8, 9, 10-year-olds who are like only doing, because their growth plates have not even
Yeah,
matured,
no.
even close, so it's, and then they're just using muscles, like, and they're not using other ones, and they're, so it's, anyway.
Did you see the Nike ad? You can't win, so win. Have you seen that one?
I don't know if I've seen that.
Oh my god, I'm gonna have to play
Is
it
it
for
on
you. I'll send it
TV
to you.
or is
Yeah,
it?
yeah, yeah. It's on
Yeah.
YouTube for sure. But it's a whole ad around like Caitlin Clark and women's sports that like all the negative stuff they'll
Uh-huh.
play like clips of all the negative, and then it's like you can't win, so just go win. Like
Right,
just go
right.
do it.
Yeah,
So like
right. You gotta think about that. You're like, oh yeah, right.
did you feel like that going through your orthopedic training? Like I skipped over that part and I want to circle back to it in the sense like were you one of like zero women?
So interesting, it's funny. I went through a time, and this was even like I went through residency at a time where there was actually I was the one female in my class, but there were two females in the class above me, and then two, like there were probably a quarter, there was like 25% of the residents, which was high. But what shouldn't be is that like everyone was like, oh yeah, PCOM is female friendly, right? That term shouldn't even exist.
Oh wow.
That, I mean, that's the problem. That's the
Yeah.
downfall. Is like, yes, there were other females. I wasn't like trailblazing like people who were my like 20 who people who went through 20 years before I did. They were probably the only one, and that
Okay.
brought a different set of challenges on.
Okay.
But then you had this phrase, female friendly residency program, and you're like, well, that's
That's
crappy.
not
I don't want to say,
helping.
yeah.
Yeah. Yeah, it's not
What I really
helping.
want to say, I'm not going to say on the air, but that's messed up. That shouldn't be a term, right? That's used. And I do think it's changing, but you feel like subtle differences of how you're treated, and you feel like you definitely have to kind of prove yourself, right, in a different way. It's just the nature of the beast.
I was so excited that one of our colleagues texted me the other day. She was covering professional baseball game or whatnot. And I get so excited when I see that because when I was a kid, there was nothing.
Yeah.
Nothing with women on TV, nothing with women in sports. I mean, I grew up in the 80s really, and I wanted to be a Padre. Don't ask me why it was the Padres. It was not the Phillies when I was little, but and there was nothing really out there until that
Hmm.
that women's soccer team kind of broke through, and then I started to slowly see it, coming. But even at let's see, I opened my practice in 2016. When I tell you the amount of you'll never get into you'll never be able to break into sports medicine, never, never, never. Mostly because you're a girl, mostly because it's boys' club, surgeons are boys' club. And 9 years later, I think we're doing pretty good.
Hmm.
So I've definitely seen a shift in the culture. And it's a credit to people like yourself to, keep digging that, like
Yep.
feeling committed enough to sports and athletes. Girls are sports like minded too. So to keep driving that train. So I
And I,
appreciate it.
yeah, and I think, like having being mentors, right, to the younger ones who are behind you, like trying to remember, I was there at one point. I know having a female mentor, right, that means a lot. Okay, like not like paving the way, but having people you can lean on and talk to about it and say, hey, what was your experience? And at the same time, the flip side is like having men who are like, okay, there's a whole like movement within orthopedics
Yeah.
now, is like,
Okay.
like, well, yeah, there's a whole speak up ortho thing, and that sort of comes to how like women were treated differently and still are treated differently. They're asked different questions in their interviews, right? There's a
Totally.
whole, yeah, I mean, that's
I
again
was
different
asked how
conversation
long
than
after I got married that I wanted to have kids so they could plan,
yeah,
whatever. I
right.
was like, what?
This is not, yeah, yeah.
Not cool.
Explain to me how this is relevant at all.
Yeah, yeah, yeah.
But things like that, and so having men who are established in the field, right, in the females' corner too.
Hmm.
That's important too.
No, it's huge.
So
It's huge, and my husband, my partner, he, despite not really being excited about opening the business per se, has been the main supporter all the way. And I wouldn't be able to do this if he didn't do what he does at home. So,
yeah.
yeah, no, it's really great to highlight it. Anything we've missed? Anything you wanna plug at the end here? What do you got coming up
Oh,
next?
coming up next, so I am starting at so it's Holy Redeemer, so it's Redeemer Health is the hospital, and it's actually a practice I was at before, and with a slightly different spin. It'll be working. It's in the same area, so it's Fox Chase, Jenkintown. Hopefully, getting to work with a couple, high school teams. Getting to do some cool sports stuff that I like doing, but also just taking care of, people who want to stay active and get better. And so that's going to be at Redeemer Hospital, which is in Fox Chase, Jenkintown area, Pennsylvania. Um,
That's
yeah, and I
awesome.
start in
You're
the
gonna
middle of
crush it.
May,
Yeah.
so hopefully
Okay.
get some of my old patients back, and they because I left a couple years ago and they were sad when I left, so rebuild back up and
Yeah.
create the name again, and
I don't think you'll have any trouble with that. It's good stuff. So
Yeah,
if
so you got to come over to PA.
I
Yeah,
know
right there.
what's gonna
It's like
happen. It's just gonna happen. I like, let's just call it for what it is. We'll talk 2026.
yeah. There you
um,
go.
so if people want to get a hold of you or see you in your office or have any
Yeah.
questions, what's the best way for them to do that?
So there's a couple ways. So my website, which is actually very easy, you go on, so it's Kaplin, Kaplin, sportsmed.com, and there's a place you can hit contact us, and it's a email, and the email is encrypted, right? But it comes directly to my email address. So I
Oh, that's
actually see
great.
anything coming through to me. A lot of them are like spam stuff, so it's like kind of annoying. But a lot of them are patients. They contact me and say, hey, I'm interested in this, or how can I make an appointment? And I'll usually have my staff reach out. But that's a great way. My office number to my office, which again I'll be starting at May 15th, is 215-745-4050. Or you can go on, the Redeemer site, and those are easy ways to make appointments.
Yeah, no,
And my
sounds
website has
great.
a lot of cool surgery, has all the surgeries I do. It has some other stuff about just questions you might have on shoulder injuries, injury prevention. I have a lot of handouts on injury prevention, knee injuries, things like that.
Yeah, you're a great educator, so definitely a great site to lock into and see. And highly recommend if you need some assistance, check out Dr. Kaplan. It's good stuff. So thanks again for
Thanks,
coming on. I
Andrea.
appreciate it.
Yes, thank you for having me. We should do
Oh,
another one.
we're totally gonna do another one.
Yeah,
This is too fun and too easy not to.
yeah,
So,
yeah.
so that's it for us today. Dr. Andrea, physical therapist with Expect More. Keep doing your thing, and we will see you in a week. Have a good
Take
night.
care. Bye, everyone.